Okay, thank you again. The first aspect that we have to evaluate when we speak about failed instability surgery is the definition of failure. If we define a failed surgery when the patient has a new recurrent dislocation and needs a revision surgery, the rate of failure after an arthroscopic bunker repair is between 5 and 15%. But probably this number is much higher if we consider other parameters like subluxation, apprehension, or residual pain. For sure, the most frequent causes of failure after a bunker repair is a new trauma. But the failure bunker repair can also be caused by hyperlaxity, insufficient number or malposition of the anchors, or error in diagnosis that fail to detect and to address bone loss or rare pathologies like humeral avulsion of glenohumeral ligaments. Patient evaluation is the first and also crucial aspect in the management of the failed bunker repair. We need to know very well the mechanisms of the new trauma, the symptoms of the patient, pain, minor or major instability, sport involvement, type of occupation, and we also analyze the previous surgical reports in order to know the exact procedure used and the number and type of anchor implanted. We also need to evaluate hyperlaxity, instability in mid-range of motion that usually indicates a critical bone loss, and we also need to detect concomitant pathologies like rotator cuff tear or injuries of the biceps. Patients need to perform a 3D CT scan in order to assess, to better assess the bone defect, and an MRI that can be helpful for assessing soft tissue quality. Nowadays, the conservative treatment after a failed bunker repair has a limited role. It can be proposed in patients with collagen disorder like Marfan syndrome, volunteer dislocator, patient with instability arthropathy, or with severe systemic pathology that contraindicates surgery. The conservative treatment is based on reinforcement of a dynamic stabilizer consisting of exercise for rotator cuff strengthening and periscapular control. Among the surgical treatment, Latarjet is the most popular procedure after a failed arthroscopic bunker repair. Historically, Latarjet is used by surgeons because it gives us great safety thanks to the benefits of the triple effect. And in fact, the dislocation rate in revision Latarjet is quite low, but unfortunately, as you can see, the reoperation rate can reach 20% and the complication is around 15%. Latarjet is the procedure we also use the most after a failed bunker repair. We usually use when we have critical glenoid bone loss, but also in patients involved in competitive sport or with a high number of dislocation, like in this case. And in our experience, revision Latarjet after a failed bunker repair give us good results in terms of stability and patient satisfaction with a slight loss of external rotation. The good news is that if we compare primary Latarjet with revision Latarjet after a failed bunker repair, the results are quite comparable. There is a slight but significant higher risk of infection and a higher risk of overall instability with revision Latarjet, but there is no differences in terms of a number of dislocation, rate of reoperation, and number of other complications, in particular osteoarthritis. Over the year, the number of arthroscopic procedure after revision, after a failure bunker repair is growing. The results of the revision bunker repair is good in 80% of patients, but unfortunately, more than 1 in 4 patients complain instability, and less than 50% of patients return to sports to pre-injury level. If we compare Latarjet with the revision bunker repair, we can see that Latarjet shows better results than revision bunker repair in terms of recurrent instability and return to sport. But on the other hand, Latarjet shows more pain, more loss of external rotation, and more complications. In order to improve the results of the revision bunker repair, we can combine a revision bunker repair with a remplissage. This procedure in non-contact athletes give us a very high stability rate, more than 90%, a good level to return to sports, and a slight loss of external rotation. We are also increasing the number of arthroscopic revision after a failed bunker repair. It's rare that we use bunker repair alone in the revision cases. We usually perform a revision bunker repair with remplissage. We usually use it in subcritical glenoid bone loss, in patients with a low number of dislocation, and in patients like in this case with that complains pain, because we think that arthroscopy can better detect and treat the concomitant pathologies like rotator cuff tear and slap lesion, like in this case where we perform a bunker and slap repair and a remplissage with good results. We can also think to combine revision bunker repair with ASA technique. This morning we see that the ASA technique gives us very good results in primary surgery. We can use it in patients with with subcritical glenoid bone loss and in patients with bad quality of anterior capsule. And also in the revision case, this technique gives us good results in the preliminary data. We can also use distal tibia allograft in the failed bunker repair. It's usually used when the glenoid bone loss is measured at 20%, and of course after Latarjet procedure, failed Latarjet procedure. The data that we have in literature are small, but the preliminary data are good too, and we have comparable results to Latarjet after failed arthroscopic instability. We usually use distal tibia allograft after a failed Latarjet, but in this case we use the distal tibia allograft in this patient with 2 failed bunker repair, and because we didn't have a very big glenoid bone loss, but the quality of the tissue, the soft tissue, was bad, and also the patient asked us for a distal tibia allograft because he did a distal tibia allograft on the other side with very good results after a failed Latarjet. Oops. We are increasing the number of distal tibial allografts because we have very good results with this technique, but it's also true that we can use it also because we have an easy access to fresh frozen allograft because we have a bank tissue in our hospital. In conclusion, in failed arthroscopic bunker repair after a precise patient evaluation, the choice of the treatment is based on bone defect, quality of soft tissue, and patient characteristics. So in patients with a subcritical glenoid bone loss with on-tracheal sacs, we can perform a revision bunker repair associated with ASA technique, or we can perform a Latarjet procedure in patients involved in contact sport. If we have subcritical glenoid bone loss but with an off-tracheal sacs, we can perform a revision bunker repair with remplissage or a Latarjet. On the other hand, if we have a critical glenoid bone loss, we can perform Latarjet or distal tibia allograft. In the future, theoretically, we can also use arthroscopic bone block, because this technique we saw this morning give us very good results, but at present we don't have experience and we don't have data in literature that can give us the possibility to use it in revision cases. Thank you.